Ladies and gentlemen, thank you for standing by. Welcome to the BRCA Mutations in Ovarian Cancer, What You Need to Know webinar. If you'd like to ask a question, you may ask a question at any time by typing it into the Ask a Question feature on the left side of your screen. It's now my pleasure to introduce your host, Samantha Deegan. Please go ahead.
Thank you for joining us for today's webinar. The Basser Center for BRCA at Penn Medicine's Abramson Cancer Center is the first comprehensive center for the research, treatment, and prevention of BRCA-related cancers. The center is devoted to funding research across the globe, educating providers and patients, and advancing care for individuals with BRCA1 and BRCA2 gene mutations. Dr. Edward and Mary Prostick have generously established this webinar as part of the Elizabeth Prostick Memorial in memory of their daughter. This video is a tribute to Elizabeth, her incredible life, and her dream of creating about BRCA cancers. The Basser Center is proud to be a part of this mission by providing hope to wide.
Tomorrow, bet your bottom dollar that tomorrow there'll be sun.
Lizzie Prostick was an amazing young woman who believed in the promise of tomorrow. And though her tomorrows were cut short, we can celebrate and sustain her optimism. Lizzie lived large. She loved the stage and brought it to life with her voice and her energy as a talented child and as she grew into a woman. Her world was full of loving friends and family, and success in class, in sports, with girls, and with boys. Sophomore year of college, Lizzie met Michael Lundblad, a liberal and an English major. He got a preview of her leanings when he saw her quizzing a friend about senators. But she learned to love camping. He learned about couture. And political opposites, Michael and Lizzie spent 10 years together, marrying their minds and their passions. Michael loved her boldness and her softness, her interest in so many different types of people, and ability to remember the small details of their lives. The time she made to talk with her grandmother, her pearls, her red shoes that said she was not afraid to be noticed. She was not afraid. Lizzie's intellect and drive were rewarded with exciting opportunities. She blazed through the University of Pennsylvania and into the halls of government, determined to win in every venue and for every cause that was important to her. Her work for senators and on committees quickly made her a Washington insider. She rose to Chief Privacy Officer and Senior Advisor to the Secretary of Commerce before being lured away to the private sector. Not yet a lawyer, she was named Managing Director at Sonnenschein, Nath, and Rosenthal in Washington, D.C., and was completing her law degree at night at George Washington University when she died. When Lizzie was awarded a posthumous degree at the law school graduation, the entire audience stood in tribute to her spirit. Lizzie was 31 when she was diagnosed with stage 4 metastatic breast cancer, and her daughter Harper was 4 months old. Michael did research. Lizzie didn't want to know the odds, expecting to beat them. But the cruel reality was that although breast cancer is generally curable, metastatic breast cancer is not. And they found little support to help them deal with the psychological and emotional realities they had to face. In her last months, Lizzie and her family began to envision an online support network that would show patients with metastatic disease that regardless of how long they have to live, they have the ability to control how they live. This was Lizzie's final cause, and one which will be honored. Lizzie wanted to see her daughter's first birthday. She didn't make it, but she lives on in the people who loved her, and through grants such as this one being made in her name. And in truth, none of us knows how long we'll live, so we all should listen to Lizzie and make the most of every tomorrow. Live large, live strong, and wear red shoes.
Tomorrow, you're
Today's program will discuss BRCA and hereditary ovarian cancer. As always, this presentation will be archived and available for viewing later this week. You'll be able to find it at bassert.org/webinar. I'd like to introduce our speaker. Ronny Drapkin, MD, PhD, is the Franklin Payne Associate Professor of Pathology in Obstetrics and Gynecology at Penn Medicine's Abramson Cancer Center. He serves as the Director of the Ovarian Cancer Research Center, the Director of Gynecological Cancer Research at the Vassar Center, and the Director of the Translational Center of Excellence in Ovarian Cancer. His research, teaching, and clinical activities focus on understanding the pathogenesis and genetic alterations involved in women's cancers, with the intent to translate these important biological principles into clinically useful diagnostic and therapeutic tools. And Dr. Drapkin, the floor is yours.
Okay, thank you, Samantha. Hopefully everyone can see my slides. And it's a real pleasure to be with you all tonight to talk about BRCA1 and ovarian cancer. And I'm going to start with a bit of a historic perspective on women's cancers. I think many of us might know that Hippocrates was credited for coining the term cancer and describing it, but it really goes back to Egyptian times. As far as 1500 BCE, there is records of women's cancers in papyri that describe not only the surgical procedures, but even how they treated these ailments. For those who are interested in this, I highly recommend the book, The Emperor of All Maladies, written by Siddhartha Mukherjee. It won the Pulitzer Prize a number of years ago, and it tells the fantastic story of cancer itself, all the way from Egyptian times to modern day. In addition to descriptions of breast cancer that were discovered in these writings, there was also evidence that the Egyptians were familiar with gynecology or reproductive tract cancers, including uterine cancers and ovarian cancer, and to describe not only the surgeries but also the therapies that they had developed for those cancers at the time. Now, if we move fast forward to modern times and we look at how often these diseases are associated with early diagnosis or early stage disease versus advanced stage disease, and you can look at ovary on the top left and breast cancer in the top right, uterine cancer on the bottom left, and cervical cancer on the bottom right, what we see is there's a general trend in all these cancers except for ovarian cancer. Ovarian cancer is really the only one where the majority of cases are diagnosed when the disease is already metastasized, where it's referred to here as distant. And this has created a lot of problems, not only in terms of detection, prevention, and treatment for this disease, but it also has a big impact on outcomes. And so if we now specifically focus on ovarian cancer, you look at the World Health Organization statistics, there's about 250,000 new cases diagnosed around the world every year. Unfortunately, the majority of these women will succumb to their disease. 152,000 of these women will succumb in that first year. And if you look at that graph on the right, you look at that 5-year survival. And I can tell you that 70 to 80% of these women get diagnosed at late stage, at stage 3 and 4, where the 5-year survival is really hovers around 30%. And it hasn't really improved all that much in the last few decades. This is in part due to the fact that we lack screening tools for ovarian cancer. We don't have, for instance, the pap smear that we have for cervical cancer, which has been shown to reduce mortality from that disease. We don't have something like that for ovarian cancer. That's part of the problem. Because we can't detect this cancer early, until recently, it really limited our understanding of the molecular features of this cancer. We didn't really understand where it started, what it started, how it started, what triggered it. And that is further complicated by the fact that we still don't have therapies that are durable. Now, another way of looking at these numbers, at these statistics, is to look at the death-to-case ratio. So if you look at ovary, the third one listed there, you see, and these are statistics from a few years ago, that there's about 22,000 new cases in the United States diagnosed every year, and about 14,000 deaths from that disease for a lethality index of 0.67. Now that puts ovarian cancer third, right behind pancreatic and lung cancer. You look at the bottom, and you see that breast cancer is almost 10 times as common as ovarian cancer, but fortunately, fewer women die from this disease. So that makes ovarian cancer 3 to 4 times more lethal than breast cancer. Now, why is that? There are some very interesting anatomical and physiological reasons for that. I'm going to try to articulate that to you in the next slide. So this is a schematic of the female pelvis. And what we see with the hip bones and the sacrum is that the pelvis of the female anatomy creates a bowl-like structure. And it's in that bowl that the female reproductive organs reside, the uterus, the fallopian tubes, the ovaries. And so unfortunately, tumors can get rather large and not create symptoms until it gets large enough that it rises out of that bowl and affects the GI tract above. And so, and as we'll see later, many of the symptoms of ovarian cancer are nonspecific because really what they're doing is irritating the GI tract above. And we'll talk about what some of those things are a little bit later on. Now, in addition to all the things I just told you about the numbers and the incidence and the lethality of this, is that ovarian cancer is actually quite similar to breast cancer in that there isn't a single kind of ovarian cancer. There are many subtypes of ovarian cancer, and what you're looking at in this schematic here at the bottom are the four major subtypes of ovarian cancer. You have serous carcinoma on the left, endometrioid, mucinous, and clear cells from left to right. Each one of these, as hopefully you can appreciate, looks different under the microscope, has a unique clinical presentation, responds to therapy differently, and that creates not only clinical challenges, because you have to really be aware of which ones you're dealing with, but also, and it creates challenges for how we think of them at the molecular level. We have to understand each one uniquely in order to be able to sort of attack it in a very specific, personalized kind of way. Now, of all these tumors, the most common one is what we call the high-grade serous carcinoma. 70 to 80% of ovarian cancers are really comprised of this tumor type. And when you hear about ovarian cancer and the dire statistics, the silent killer, it's this subtype that we're talking about. This is the one that's associated with all those poor outcomes. Now, I think it's quite apropos that we are having this webinar now because this year really is a celebration of the 25 years since the BRCA genes were cloned. And it was the cloning of the BRCA genes that started to turn the tide on this terrible disease. So the BRCA genes were cloned in the mid-90s. By the late 90s, we were offering women who harbored these mutations the opportunity to reduce their risk of dying from this disease by taking out the organs at risk. So this meant mastectomy for women to reduce breast cancer risk and taking out your fallopian tubes and ovaries to reduce ovarian cancer risk. Now, I'm a pathologist by training, and so at that time I was a resident, and this afforded pathologists like myself the opportunity to look at these specimens and start wondering whether we could find early cancers in otherwise normal women. These were younger women who were having their tubes and ovaries taken out to reduce their risk of getting ovarian cancer. Could we find early cancers there? And why did we want to do that? Because we felt that if we could find the early cancers, the precancers, and intervene, we might be able to prevent the cancer from taking hold. And this is sort of the analogy of the match that gets extinguished, right? Could we find that out? The problem was that for ovarian cancers, we didn't know where those precursors were. When those specimens were removed at surgery, there was a lot of attention to try to find the precursor in the ovary because we thought of this as an ovarian cancer. And so we were trying to find the precursor so that we could prevent that brush fire, which would obviously prevent the advanced cancer and the forest fire that obviously takes hold. And so the challenges were, where is this precursor to ovarian cancer? Paradoxically, early reports as early as 2000, 2001 started to notice that even though we were looking for ovarian cancer, when we found abnormal cells, they tended to be in the fallopian tube rather than the ovary. These are just two papers, two titles of papers that were published in 2000 and 2001. I don't want to spend too much time on those details, but these are some of the first papers that get credited for describing these early weird changes in the fallopian tube. And there were others that followed over the next 5 or 6 years. Now, by then I was a resident in pathology, and my mentor, Christopher Crum, and I decided, and a few others decided to let's look at this a little bit more carefully, because either this is quite paradoxical and perhaps it suggests that there's something else going on, or maybe we've been sort of looking at the wrong place the whole time. And so how do we do that? We developed a system that we called CFIM, which stands for sectioning and extensively examining the fimbriated end of the fallopian tube. Okay, so let me take you through this. So if you look at the picture, the photo on the top left, that is what a fallopian tube looks like when you take it out of the body. So just for analogy purposes, think of your arm as a fallopian tube. The tube is your arm, and your hand and your fingers is the fimbriated end. All these little projections that your fingers make up. The job of the fimbria is to make sure that the egg that gets released every month during ovulation makes it into the fallopian tube and travels down to the uterus, where it might either get implanted or not. So we wanted to study what's happening in the fallopian tube, because amazingly no one until this point had actually ever paid attention to the tube. It was thought to be mostly a conduit, a tube, almost like the appendix, of no consequence. So we decided, let's look at the fimbria, let's cut it into sections as you see on the top right. Let's look at the rest of the fallopian tube in the bottom left there, and then see under the microscope what's actually going on in the fallopian tube. Why are we seeing these weird, abnormal cells in the fallopian tube and not in the ovary? Now, to really appreciate this, I'm going to give you a quick primer on histology. I want to make sure you can appreciate the differences. So, it's important to, in order to be able to appreciate abnormal, you have to know what normal looks like. So here's an example of what normal fallopian tube epithelium looks like. And so you have the thin little arrows there pointing to cells that have these sort of hair-like projections, and we call those ciliated cells. It is those cells that actually make sure that that egg travels down to the uterus every month. The number of ciliated cells goes up during ovulation to make sure that it can brush that egg down into the uterus each month. And the bigger arrow is pointing to what we call the secretory cell. These cells lack those little hair-like projections. And hopefully what you can appreciate is that these cells are relatively well behaved. They are one next to the other. They're not piled up. They don't look quite, very different from one to the other. The nuclei are about the same size. Now, how does abnormal look like? So this is what we call serous tubal intraepithelial carcinoma. So for those of you who've heard webinars on breast cancer, maybe you've heard the term DCIS, ductal carcinoma in situ. This is cancer. This is the same thing in the fallopian tube. This is a cancer that is a bona fide cancer. These cells are malignant cells, but they have not invaded yet. Okay, so they have not gotten access to the blood vessels and the lymphatics, which is what really creates metastasis. So the thought is, if you could find these cancers before they invade, perhaps you can actually reduce the number of deaths from this disease. So there was normal and abnormal, and the question was, what's going on in the tube? Well, I'll give you the punchline. What we found is that many ovarian cancers actually begin in the fallopian tube. It's not actually ovarian tumor, as you see in quotes there, but it's actually tubal cancer that secondarily involves the ovary. And most of these early precancers are found in that very fimbriated-like end, the part of your hand and your fingers whose job it is to make sure you catch that egg each month. Now, what does that look like? So what you're looking at here in the first panel is, again, what normal fallopian tube looks like, the fat arrow pointing to the secretory cells, the thinner arrow pointing to those ciliated cells with the hair-like projections. And what we're doing underneath that top image, the H&E image, is staining for proteins like P53, which is a tumor suppressor that's commonly mutated in ovarian cancer. And what we're looking for here is brown staining. If there's brown staining, it means that protein is abnormal. It's mutated. And in normal epithelium, we don't expect to see any brown P53 staining, and we don't. If you look at the next one, this symbol of gamma H2AX, that's a marker of DNA damage. So it stains and it gets activated when there's breaks in the DNA, which is, again, abnormal. In normal epithelium, we don't expect to see it, and we don't. And again, we're looking for brown staining. And then the last one is MIB1, which is a marker of proliferation. Normal fallopian tube epithelium is not very proliferative, and we don't see evidence of proliferation here. But what we found by using the CFIM protocol is what we term the P53 signature. These are secretory cells. So now all the ciliated cells are gone. These are just secretory cells. They stain very strongly for P53, and as I'll show you later, that means that it actually has a P53 mutation quite early on. They stain for evidence of DNA damage, as you see in that H2AX stain, but they don't actually proliferate, as you see in the bottom. They're not quite proliferative yet, but they actually have DNA damage, and they've had a mutation in P53. And in the BRCA mutation population, those precursors could progress into these intraepithelial cancers. So these are now those in situ cancers that have not invaded yet. They look abnormal in the top panel there on the H&E. They stained for mutant P53, they stained for DNA damage, but now they've acquired that proliferation. Now they're proliferating, right? And soon thereafter, we worry that they would invade and now give you the clinically evident disease, which is what you see all the way on the far right there, which is an advanced ovarian cancer. So by looking at the fallopian tube, we were able to map out this progression from normal fallopian tube epithelium to ovarian cancer, and we were able to come back to our question of where do these tumors arise and fill in the fact that they begin with mutations in P53, they progress into what we call the stick lesion or the early cancer, and they give rise to that forest fire, that clinically advanced ovarian carcinoma, which has been so problematic. Now, the advent of the CFIM protocol, and that's a photo of my mentor, Chris Crum, who developed this protocol, really gave us insight into this disease. It really did point to the fallopian tube as the problem for ovarian cancer. And yet the genomics lagged a little bit behind our understanding. The first evidence where we could really point to some of the genetic alterations in this cancer came from an effort from the NIH, the National Institute of Health. And back in the late 2000s, they decided that they would invest a lot of resources in trying to develop a comprehensive catalog of all the alterations in cancer by collecting hundreds of samples of every single kind of cancer and really diving deeply into all the alterations. Now, the first three cancers that they picked were brain tumors, lung cancers, and ovarian cancers. These are three tumors that they chose because they all lack early detection, they all lack effective, durable therapies, and they claim the lives of too many patients. And so ovarian cancer was really one of the pilots of this disease. And the results for that were published around 2011, and what they showed for us in the advanced cancer is that, as I mentioned, P53 mutations are pretty much 100% of these cases have them. And what they also noticed was that about half of these cases have defects in the BRCA genes. Either they have mutation in the BRCA gene itself, BRCA1 or 2, that you inherit from mom or dad, or the expression of the BRCA1 or 2 gene is suppressed by a process we call DNA methylation, or they acquire the mutations for BRCA1 or 2 in the actual tumor itself, or there's mutations in other genes that cooperate with BRCA1 and 2 to execute effective DNA repair, or what we call genome stability. So about half of them have a defect in this BRCA1 network of proteins involved in DNA repair. And the other half seem to be rather proficient in DNA repair. And what makes them different has been an area of a lot of investigation in the last few years. So this is a complicated cancer, and we wondered, well, how is it that you go from normal-looking cells on the left there to a cancer that's so genomically complicated? And so now that we knew where to look, we decided we asked whether we could go sort of backwards in time and look at each of these precursors to ask what has happened. Can we actually provide now genetic proof that this is where these tumors are coming from? And that's exactly what we did a couple of years ago in collaboration with colleagues at Johns Hopkins University. I don't want to spend too much time on the details of this slide. It's just to sort of give you the snapshot. We looked at cases of women who had ovarian cancer where we could find the precursors in the fallopian tube, the ovarian cancers, and some metastases in the peritoneal cavity. And we did what we call whole genome sequencing and whole exome sequencing to look at what the alterations were in these tumors. And what we essentially found was what I've already sort of described, which is that P53 mutations are common. It's actually the only mutation that's common across all ovarian cancers. There are no other sort of what we call recurrent mutations in ovarian cancer. P53 is really the only one. But that as you move away from the fallopian tube, all these lesions acquired additional mutations from left to right. There was an increase in the number of mutations, further providing evidence that this is really where these tumors are coming from. So in addition to the P53 mutation being early, we also found that there was deletions and amplifications of various chromosomal pieces in the genome that was quite complex, and actually more complex than has been seen in other tumor types. And then a very interesting sort of mathematical process that we were able to develop enabled us to figure out the timing between a precursor, precancer like the stick, and clinically evident ovarian cancer. And we were able to figure out that it's about 6 to 7 years between a precursor being there and an ovarian cancer being detected clinically. This number is actually quite robust because a paper was published recently this year from a different group who did a similar analysis, and they came up with the exact same number. It's about 6 to 7 years between a precancer in the fallopian tube and a clinically evident ovarian carcinoma. Unfortunately, once it gets to the ovary, it spreads to the rest of the peritoneal cavity within less than 2 years. So the window of opportunity that we think about in terms of prevention and early detection is that 6 to 7 year window between these early cancers in the fallopian tube and when we find them clinically. Okay, so we now know that these ovarian cancers begin in the fallopian tube, and I can tell you that there's been a lot of work in the last few years from many groups across the globe who have concluded a very similar conclusion, which is that the tube is a site of origin. What can we do about it? I think a lot of you may have questions about screening and detection, prevention. What can we do about it? So let me tell you a little bit about what actually is happening today. So for prevention, I told you that the standard risk-reducing surgery is what we call a bilateral salpingo-oophorectomy. What does that mean? It means that we take out your fallopian tubes and your ovaries, and that is what we call risk reduction salpingo-oophorectomy, right? That's the first bullet point there. The problem with risk reduction salpingo-oophorectomy is that you take out your ovaries at a young age. And just to give you a reference point, for BRCA mutation carriers, the recommendation is to have risk-reducing surgery at age 35 around the time, hopefully, if you finish with childbearing. For BRCA2 mutations, it's around 40. So now you're saying we're going to remove the organ at risk at an age where you're possibly decades away from menopause and put you into menopause, what we call surgical menopause. And it has all the associated morbidities of cardiovascular disease and bone disease and urinary incontinence and so on that come with menopause at a much younger age. It's significantly a deterrent for about 30% of carriers who either want to delay or even refuse having risk-reducing surgery altogether. And so for those women, we are now offering through clinical trials the opportunity to say, oh yeah, you know what, let's take out the fallopian tubes now. That's not going to put you into menopause, right? So this is interval salpingectomy. Take out the tubes now. We believe that that's where these tumors are starting. And then follow that up with a delayed oophorectomy. Come back in a few years and take out your ovaries, okay? This trial, which started at MD Anderson, is now at 8 other sites across the United States. Penn is actually one of the most recent sites to join, is called WISP. It stands for Women Choosing Surgical Prevention, and essentially enables us to look at, in this WISP-1 study, whether doing this is actually safe. And so the primary endpoint for this is quality of life. We want to make sure that we don't intentionally or unintentionally put women into menopause by taking out their fallopian tubes, and we want to make sure that it's a safe procedure. So 8 sites have been participating in this. We've been actually accruing quite a number of patients at Penn. Sarah Kim is the lead clinician on this. And I can tell you that the interim analysis has come back, and the results suggest that it is a safe procedure, that we do not recommend someone doing this outside the setting of a clinical trial. But the results are encouraging enough that, as you see on the right there, there's already plans for a WISP-2 and another study that's being done, very similar study in the Netherlands called TUBA. It's going to be TUBA-2, where now we're going to look at thousands of women, probably in the range of 2,000 to 3,000 BRCA mutation carriers. And the goal of those studies is really going to be, have we given these women equal risk reduction by just taking out their fallopian tubes? Okay. And then there's a third study, which is labeled there NRG CC008, which was recently approved by the NCI to do a similar analysis in terms of the population of BRCA mutation carriers, offering them these options for risk reduction. So this is something that already, right, is having an impact at the clinical setting through these clinical trials, and we'll see. I think the data will tell, will reveal whether in fact the fallopian tubes, if you remove them, will give you similar risk reduction, and maybe we don't have to subject women to surgical menopause. So that's one sort of trial that's ongoing now that there's a lot of interest in. The other, it really comes to early detection. So how do we detect it early? We talked about how there isn't a pap smear for ovarian cancer. Pap smears for cervical cancer. We don't have anything like that. So there is a company called Envision Medical, recently acquired by Boston Scientific, that developed what's called Cytuity, or the Mako 7 device. Now, these are bioengineers. These are smart people. And they said, okay, if the fallopian tube is truly the site of origin for these cancers, there must be a way that we should be able to sample the cells in the fallopian tube, essentially creating a pap smear-like tool for these women. And so they didn't want to reinvent the wheel. They took a procedure called the hysteroscope or hysteroscopy, which is an outpatient procedure designed to enable physicians to look into the uterine cavity, into the uterus, to see whether they can explain in cases of infertility why is someone infertile, why they may have abnormal bleeding. And so that already exists, and they thought, well, maybe we can add a component of the hysteroscope that would enable us to look in the fallopian tube. And what they came up with was a balloon catheter that can be deployed into the fallopian tube. They didn't want to manually try to cannulate that because there was risk that you would perforate the tube. That's not a good thing. So the balloon follows the contours of the tube in the path of least resistance, which is the lumen itself, the actual tube itself. And the surface of this catheter has a tacky sort of texture to it, such that you can actually sample all the cells in the fallopian tube, and when you retract it, what you essentially have is a pap smear of the tube. So this was a phase 1 study that was done initially at the University of Virginia and showed that it was safe, that there was no complications. And now they've opened up a much larger phase 2 study across the country. Penn actually is not only enrolling in this study, but is actually one of the fastest accruers next to Kaiser Permanente that's been involved in this since the beginning. And so this is a trial that we're offering patients who are going to, initially there's 2 arms to this. One is a group of patients who are going to have surgery because they have a suspicious mass. And so now we can look in the tube and see whether the cells that we detect with this device match what comes out at the time of surgery. That's already shown that it's a greater than 90 to 95% concordance rate. We've been in conversations with Dr. Domchek, the Bassler Center, to start thinking about how could we deploy this in the high-risk population, in women who have the mutation for BRCA1 or BRCA2. And so this is something that may ultimately become a tool for early detection that we don't currently have. But again, these trials are actually happening. And so it gives us an opportunity to really think about what the future can look like. So the challenges for early detection and prevention. There's been a lot of interest and questions related to a blood biomarker. So many of you may be familiar with CA125, which is a marker that was discovered in the early 80s and is actually used and approved by the FDA for tracking patients who have ovarian cancer. And so it's quite useful when you know a patient has ovarian cancer that you can follow their disease. The CA125 it should come down after surgery, it should come down after chemotherapy, and sometimes we can actually track CA125 to look for evidence of recurrence. Unfortunately, CA125 isn't sensitive enough or specific enough for early detection. So in the general population, when you have a mixed population, it has not been able to demonstrate that it's useful for early detection. There's another FDA-approved marker called HE4. We worked on this some years ago. It's a little bit better than CA125. It's a little bit more specific. And the combination of CA125 and HE4 definitely gives better results with regards to screening. And yet, even that isn't good enough and not sensitive enough for population screening. And so why is that? And part of it is because these early cancers, which is what you're trying to get, right? Remember, we're looking for that precancer in the tube, really secretes proteins that get massively diluted in the blood. And we're going to talk about what that looks like in a second. In the blood, you have lots and lots of different kinds of proteins. There's 12 orders of magnitude in regards to the number of proteins in the blood. What does that look like? It's hard to wrap your head around, but we're going to describe it to you. So here is a somewhat complicated looking figure where on the bottom, on the x-axis, are names of a lot of proteins that are present in the blood. On the ones on the left, they're very common. On the ones on the bottom right, they're very rare. And the problem is that if, and those are the 12 orders of magnitude I just highlighted to you on the y-axis, if you're looking for a protein that is highlighted by the red boxes there in the blood, it's challenging, and that happens to be PSA for prostate cancer. It's actually hard to find it because all the other proteins that are much more common sort of make it hard to find it. It's like looking for that needle in the haystack. Another way of thinking about this is that if you're a fisherman and you're trying to catch your little fish at the very bottom right there in the Marianas Trench, you have tons of other fish in the different depths of the ocean that are going to get to your bait before it ever gets to your little guppy at the very bottom there. Right? So there's a huge dynamic range problem. I want to illustrate to you another way of looking at this. So imagine for a moment that this ant is your biomarker. If you get down on your hands and knees, you can look at that ant and say, yes, I see you, you're an ant. Now let's move away from that ant about 4 to 5 orders of magnitude and look at it from a little hill in the city. That ant now is much harder to pinpoint. That's that yellow arrow there. If you move away from that ant about 6 orders of magnitude, now it's looking at it from a mountain, quite hard to find that ant. And if you look at it from 12 orders of magnitude, which we're talking about in the blood, it's like trying to find that ant from the moon. It's very, very difficult, right? So that's one problem, dynamic range. The second problem is the source of ovarian cancer. Where are we going to look for it? Well, we just told you that the majority of these tumors actually arise in the fallopian tube. So at least we know where to look. So over the past years, and this is all work that's been developed in our labs and other labs, we've been developing systems to look at the fallopian tube so that we can start asking what's the difference between a normal fallopian tube and a cancer fallopian tube, and can we identify proteins that might be useful for early detection. So with this slide shows you some of the different types of model systems that we've developing. And I want you to really focus on just the first one, which is what we call the ex vivo fallopian tube epithelium bioanalytic platform. It's a mouthful, but essentially all that is that we're able to take cells from the time of surgery and from the fallopian tube and grow them in these culture systems. And in those culture systems, they amazingly behave very similar to how they behave in vivo. And so what we're able to do now is culture normal cells and a matched tumor from the same patient and ask the question, do the tumor cells secrete something different than the normal cells? And so this is just illustrated in the next slide here, where on the right you see normal fallopian tube. This is what these cells look like on these membranes of these cultures, and a cancer cell on the bottom. And we can ask now, using analytical tools like mass spectrometry, do the cancer cells make something different or at higher levels than the normal cells? And this is all work in progress, but there's already a number of biomarkers that have emerged from this that are actually being developed, not only in the clinic, but we're in conversations with companies that want to further take this into larger cohort studies. And it's giving us now the opportunity to really start thinking about early detection because we know where to look. Okay? And I think I'm going to end with that and give you the opportunity to answer some questions. I just want to close by acknowledging people, not only at the University of Pennsylvania, these are the people in my lab, the photos of folks in my laboratory, my colleagues at the Vassar Center, Susan Domchik, Roger Greenberg, Kate Nathanson, Lauren Schwartz, who's our pathologist, and a number of others, in addition to collaborators I've had the pleasure of working with over the years on the right. And with that, I would love to take some of your questions. And I'm looking at some of the questions that you have in the question box here. So the last question I see is, do we yet know the percentage of BRCA-related cancers that do not originate in the tubes? That's a very good question, and that's been an area of a lot of investigation. So what I told you is that it appears that many of them, if not most, originate from the fallopian tube. And in some studies, the numbers range from 40 to 60% of ovarian cancers in the BRCA population can have an associated precursor found in their fallopian tube. But in some cases, we don't find a precursor. And so the question is, well, where is the precancer? If it's not there, did it come from some other place? People have looked. People have wondered whether it's on the surface of the ovary or some other cell that contributes to this. Unfortunately, we have yet to find evidence that's comparable to what we've seen in the fallopian tube where we can find a precursor somewhere else. There's the other idea, and this is what's called a precursor escape concept that's recently emerged, which is that maybe the fallopian tube cells can leave the fallopian tube. They can get shed, they can get sloughed off from the fallopian tube before they become cancerous. And they can sit on the surface of the ovary, or they can sit somewhere in the peritoneal cavity and there become a cancer, such that when the cancer grows and you look in the tube, you don't see anything there, but maybe the cell was actually originally from that tube. And so there's some interesting genomic data that suggests that maybe even some of those are actually from the fallopian tube. It just didn't start as a precancer there. It started as a normal cell that got sloughed off from the tube and landed on the ovary or the peritoneal cavity. Okay, let me see. One question is it only the serous types of ovarian cancers associated with the tube? It's a really good question. So we think, if you recall back to, and I'm going to slide over some of the slides we looked at here. Okay, so we look back at this slide. I told you there's multiple types of ovarian cancer. The high-grade serous cancers, the one we've been focused on, seems to certainly have a majority of them coming from the tube. The other subtypes, endometrioid cancers and clear cell cancers, are thought to be associated with endometriosis. And endometriosis is essentially cells from the uterine cavity that end up on the ovary or the peritoneal cavity through retrograde flow from the fallopian tube. And these are associated with the emergence of these clear cell and endometrioid tumors. And then the mucinous tumors, a lot of controversy over the years about whether there's really such a thing as an ovarian mucinous, or whether maybe it's confused with GI or bowel tumors, because they can also look mucinous. It seems like the real frequency of mucinous tumors is considerably lower than we thought, but that there probably are some that are mucinous. And where they come from is somewhat still debated. So what's emerged is that perhaps many of what we used to call ovarian cancers don't actually originate in the ovary per se, but they end up in the ovary from other sorts, from other sites. There's a question here about, in the absence of organ removal, what are the monitoring options? And I think we covered a little bit of that in terms of what's happening in the clinical trials, right? So we see that this device that was developed by Envision Medical, the Cytuity, let me just get back to that. This device here that is using a hysteroscope to really be able to sample the cells in the fallopian tube is being tested now. And we think that these approaches, if deemed safe and easy to deploy, may be something that could be seen in the high-risk population initially for screening in the absence of having to take out your tubes. Certainly, in a family might have a BRCA mutation and you're in your 20s or you haven't had your children yet, this is something that could impact those young women. Does age play a role in the onset of BRCA-related ovarian cancers? Certainly, it seems to. The BRCA mutation is associated with a higher lifetime risk of getting ovarian cancer, and it seems to be more penetrant. And so for those reasons, we tend to encourage women to have prophylactic surgery at a younger age than BRCA2 mutations, which also have a high risk, but not as high as BRCA1 mutations. And so definitely age separates the BRCA1s from the BRCA2s. Let me see. There's a question here about what research is being done on PARP inhibitors and BRCA-related ovarian cancer. This is a huge area. Excellent question that we didn't really touch on therapy this evening, but absolutely there's this tremendous amount of work being done on PARP inhibitors. PARP inhibitors are really taking advantage of the fact that the BRCA tumors have a defect in DNA repair, because you'll recall that this is the real function of the BRCA proteins. And so they already have one defect in DNA repair, and the PARP inhibitor really kind of takes the legs out of the remaining DNA repair that those cells have, and so it really leads to the death of those tumors. And so that's single agents and combinations of PARP inhibitors with other drugs are being tested now in clinical trials. We have a number of those ongoing at Penn, and we're quite enthusiastic about where that's going to go. It's really going to change the face of how we treat this disease, not just when the tumors occur, we think this is going to end up being part of upfront therapy. And so those are ongoing studies, very exciting time with regards to not only the therapy, but even perhaps bringing it up front. A question on early detection, I think we've talked a little bit about that. We think that this device might be helpful. The biomarker work that we're doing, comparing the proteins that are being secreted from matched tumor versus normal, has really elaborated some interesting candidates that we are taking from the bench to the bedside, so to speak. And so we hope that there'll be some new markers, more robust markers to add to C125 and HE4, which we already talked about. Let me see what else. What do we got here? Would you recommend fallopian tubes be removed only a couple of years before the entire ovaries are to be removed? For example, in a 42-year-old who's been recommended to have ovaries removed at age 45 for BRCA2, would fallopian tube removal push out the need for ovarian removal? So I think, you know, the older you get, I think it becomes less of an option. So the longer you wait to do the prophylactic surgery, the more the risk is. Remember this 6-year window, right? We don't know when these precancers start. We know that there's this window of 6 years that we want to try to capture and do this, whatever prophylaxis we're going to do, before those cells ever make it to the ovary. And so the sooner that gets done, the better. I would be in favor of doing tubal removal at a younger age, where you can preserve your fertility without going into menopause, but I would not be in favor of pushing it too close to the recommended age. And, you know, right now the WISP-1 study is essentially saying, we're going to remove your tubes now, and we're going to come back 2 years from now to take out your ovaries. And that's also part of that trial, is to figure out how many women actually come back to get their ovaries removed, because we want to make sure that that happens and we don't omit the removal of the ovaries, because this is a trial. The trials are done because we don't have all the answers, and so we need to make sure that we don't leave anything there that might be at risk. How likely is it for BRCA cancer to morph into a small cell cancer? So small cell carcinomas of the ovary, there's a particular type that afflicts very young women. It's quite deadly, but it's not associated with BRCA mutations, and I don't think I've ever seen a BRCA tumor differentiate or change into a small cell carcinoma. They're quite different. The mutations in the small cell tumors, especially what we refer to as a hypercalcemic type, are very unique. It's a SMARCA4 mutation. It's a chromatin remodeling complex that gets mutated, not the BRCA gene, so they seem to be quite different. See, I'm a 33-year-old. If I were to have my tubes removed and live my life, what is the risk? That's the question. Here's the actual dilemma. We think these tumors come from the fallopian tube. So of course you say to yourself, well, let me have my tubes removed. I don't have to have menopause. I can maintain my fertility. What's the risk? What we don't know is, when do those cells leave the tube, right? When do the cells shed from the tube and land on the ovary? You can imagine a scenario where that happens, and now you take out your tubes and you think you're safe, and then later you get an ovarian cancer because the cells left before you had your tubes taken out, and we just don't know the timing of that yet. This is what we're hoping some of these trials are going to help us determine. So none of this is really recommended outside the setting of clinical trials. That's why we're doing them, but we're hoping we're going to get better answers to this, and we're even continuing to study this in the lab with animal models to really help us figure out what's the likelihood of these cells to leave, what really drives them to leave if and when they do, how does that affect our strategy for risk reduction. Do we yet know the percentage of BRCA-related ovarian cancers that, I think we covered that one before. In the absence of organ removal, the monitoring options, I think we covered that. Can birth control lower the risk of ovarian cancer if you have a BRCA mutation? Excellent question. So one of the things that we didn't touch upon are, what are the modifiable risk factors for ovarian cancer? It's obviously family history is probably the most important piece to all this, in addition to knowing your BRCA status. But we also know that, and this is from data that's existed for decades and has been reproduced a number of times, that what we've referred to as incessant ovulation, which means if you ovulate without ever stopping, meaning if you ovulate and never take birth control pills and never have kids and never breastfeed, your risk of ovarian cancer is higher than if you do any of those things. And that's true for the BRCA mutation carriers as well as the general population. So if you stop ovulation, that is associated with decreasing your risk of ovarian cancer. If you don't stop ovulation, so it's incessant, month to month, year to year, that's associated with a higher increase of ovarian cancer. And the question that we think about in the lab is, well, why is ovulation driving this, right? And we think that part of it is that when that egg gets released every month, it gets released with a number of other factors in that follicle that are a little bit sort of toxic to the surrounding cells. And most of the times those cells repair themselves and it's not a problem, and you know, month to month they tend to recover. But occasionally they may lead to alterations, to mutations in genes like P53 that might set up sort of the stage for an early cancer perhaps. Most of those early changes don't progress to cancer. Most precursors in general, regardless of what organ you're looking at, will not progress to cancer. But in the BRCA population, they're more likely to because they already have one of the BRCA genes defective. And so it's easier to lose the other one and drive that cancer or that precursor into a cancer. Covered some of the screening questions. Sam, do you see anything that I may have missed that I should try to address here? I'm trying to go to the end here.
I don't think so.
Let's see. So there's a question here about does serous endometrial cancer likely start in the ovary? That's a really good question. This is someone who's probably been reading some of the research coming out. So endometrial cancers, just to begin with, right, are the most common gynecological cancer. Fortunately, they present at an early enough stage where it doesn't claim the lives of as many women as ovarian cancer does. So it's the most common, but ovarian is the most deadly. So within endometrial cancer, like ovarian cancer, there are many subtypes. Serous endometrial cancers are particularly aggressive. They're very similar in some ways to the serous ovarian cancers. And while they're thought to sort of arise from the endometrium, the question has come up whether some of these fallopian tube precursors might not only shed to the ovary, but maybe even shed into the endometrium itself, just the same way that that egg gets pushed into the endometrium every month, and whether that could be a connection. So people have been doing genomic studies that sort of ask, you know, what percent of these serous endometrial cancers may actually have their origin in the fallopian tube as well. And so that's an interesting area that there's some studies that suggest there are, but it's clearly not the majority, but they're very similar in that regard. Let me see. Okay, should patients routinely have their tumors evaluated for biomarkers? So I'm not totally sure what you mean by biomarkers. Right now the recommendation is for any patient who has an ovarian cancer that they should get their tumor sequenced, because it turns out that the frequency of BRCA mutations, whether you inherited them or whether they got mutated in the tumor, is considerably higher than we used to think. We used to think that hereditary ovarian cancers were about 5 to 10% of all cases. Actually, it's closer to 20. And so those studies have really driven the recommendation that if you get ovarian cancer, whether you had a family history or not, you should get sequenced for the BRCA genes, not only because it impacts genetic counseling for you and your family, but now we have PARP inhibitors that may make a difference in what kind of treatment you might get as well. And so that is the current recommendation with regards to getting your tumor sequenced. Let's see. So there's a question here about what's the risk, I think, the primary peritoneal carcinoma in a BRCA mutation carrier after risk reduction. So I think I did touch on this a little bit. It's that issue. So primary peritoneal carcinoma is a tumor that looks exactly like high-grade serous ovarian cancer, but is detected or thought to be arising in the peritoneal, in the abdomen somewhere. They look very similar. And the question, it was thought to be actually a separate disease until this idea that the fallopian tube is a site of origin for high-grade serous tumors. These primary peritoneal carcinomas have also been associated with precursors in the fallopian tube, just like the high-grade serous ovarian cancers are. And so the question is, well, what's your risk? If you take the tubes out, you know, what's the risk of getting a primary peritoneal carcinoma? And it comes back to sort of some of the same things we talked about, which is that, yes, you take the tissue at risk. In theory, you should not be at risk anymore, but we do see a small percent of patients, I think it's less than 5%, who will present with a primary peritoneal carcinoma years after they had the risk-reducing surgery. And I think that's because we just don't know whether at the time that we do that risk-reducing surgery, those cells have not already left the fallopian tube and are sitting idly dormant perhaps in the peritoneal cavity, and years later, under whatever stimulus, they begin to grow as a cancer that in theory you shouldn't have had because you had the prophylactic surgery. So those are sort of some of the physiological parts that we still don't know, we're still trying to figure out. But it's not a huge percent. It's a small percent, but it does happen. Let's see. Okay, I think I covered most of the topics. I'm sorry if I missed any, but I'm going to turn it back over to Sam. Thank you very much, everyone. It was really a pleasure being with you tonight.
Yes, thank you so much, Dr. Drapkin. And as I said at the start of this webinar, this will be archived, and we will have it up on the website in a couple days. We'll put it on our YouTube channel and share it on social media. So I hope everyone enjoyed the webinar and have a good evening.
Thank you, Sam.